Thank you for that very nice introduction, and I'm glad to be here. It's been a very quick learning experience, and I appreciate that you've invited me and that it's tied to the walk, which is the first walk that we have done in Arkansas, so that's good. We're going to talk just about general things. You've already heard a number of the statistics that I'm going to show you, and then we're going to talk about myths, and then risk factors, and finally how to deal in a one-to-one way with someone who may be suicidal. I don't know where I point. Oh, there we go. It's just slow, I guess. Is that right? Anyway, so approximately 32,000 people died from suicide in 2005. We get our statistics from the CDC, and they're always slow. So the CDC will actually put out statistics for 2006 probably in January. So we're a little bit behind, and we don't know which way the suicide rate is going. That means that every 16.6 minutes someone dies by suicide. And although the suicide rate actually fell in the early 90s up till about 2000, from 2000 on it's been fluctuating, and it actually rose in 2003, in 2004, and fell a little bit in 2005, but not as much as we would have expected. And there was just an article last week showing that the suicide rate in women and men, but women surprisingly, between the ages of 45 and 64 had increased 35% from 1999 to 2005. So the suicide rate is alarmingly high. Now, suicide is the third leading cause of death in adolescence. It is the second leading cause of death in college students, and it's the second leading cause of death of all men and women between the ages of 24 and 34. And it is the fourth leading cause of death in people between 18 and 65. So if you're not elderly, your chances of dying by suicide are pretty high compared to other illnesses. Actually, though, suicide is highest in men over the age of 85. It's just that it's not the leading cause because men over 85 die for many different reasons, but still it is highest in people over 85. And all these suicide rates are higher in the United States in the West than in the East. And I had somebody ask which state had the highest rate, and I had to say it's either Washington, Oregon, Nevada, or Alaska. Those are at least the top four. I'm not sure. They vary in their order. So the suicide rate was 11 per 100,000 in 2005, and it's almost twice as frequent a cause of death as homicide, and it's much more frequent a cause of death than death from AIDS and related disorders. So it's really a public health problem that is not recognized and not discussed. Now, the most important thing, if you take nothing else home from this lecture, I hope you remember this, and that is that most people who die by suicide have a psychiatric disorder. It's not a kind of out-of-the-blue incident. The most common disorders have already been mentioned. Major depression accounts for 60% of all the deaths by suicide. Alcohol and substance abuse are also very common. Bipolar depression is common, schizophrenia. All the psychiatric disorders have their major cause of death, especially in the early years, is suicide. So you've got to remember that if you know someone who's depressed, depression can be fatal. It is an illness that takes people's lives. And it's impossible in any given person to identify that this is the person who will die by suicide. They actually followed, they did all these psychological tests and all sorts of things on 4,800 vets, and they followed them because they had good records prospectively for years. And when they looked at who actually had died by suicide, they could not predict from these cross-sectional data which ones did die and which ones didn't. So it's an individual case, and that's why it's very hard to study and to interrupt. There's no typical suicide victim. Now, in one autopsy study, most of these statistics, and there are 117 studies now on suicide, come from psychological autopsies. And what that is that a team of doctors and researchers goes into a home after the death, with the permission, of course, of the person, the survivors, and interviews everyone who knew the person at the time of death. And this is usually in the first 6 months after the death. They talk to the doctors or the hospital or whoever, the clergy, whoever was involved, and they ask systematically about questions. Was he depressed? Was he not sleeping? Was he gloomy? Was he tearful, etc.? And they decide, based on all those interviews, whether the person had a psychiatric disorder or not, and also whether what the disorder was. And so the statistic that 60% had a major depression comes from these studies that are from all over the world, and the findings are the same. It's quite impressive. And actually, in those studies, another one of the facts was that only 18% of the people who died had told their doctor or professional that they were thinking of killing themselves. However, adolescents talk about it to their parents and friends, especially online and on chat rooms and stuff like that. And the elderly, 45% of them tell their primary care physician, I'm really depressed, I wish I were dead, life's not worth living, all these statements that are tied to being depressed. So at least in some instances, you can get a hint that this person may be suicidal. Now, 20% have told an immediate family member, as I say, but more adolescents. And 20%, I'm sorry, this is on whether we know someone who's died, and 20% of us actually know someone who's killed himself, and 60% of us know by inference someone. The 20% have an immediate family member, and 60% have a friend or someone who's died by suicide. So it's very common. Prevention is just a matter of having a caring person at the right moment and the right place. Now, there are myths about suicide, and I just want to go through those. People who talk about suicide don't kill themselves, don't complete it. That just isn't true. The data show over and over again, when someone who dies by suicide, they've told other people about their intention, again, by giving things away or asking about where to buy something or another. So they give hints to the people in their surrounding. So you always should take any comment about suicide seriously. Suicide happens without warning. That's sort of the second kind. And then many people give these warning signs, like I had a patient who was depressed. He was a physician, and he went out and bought a black suit and a black tie. And you say to him, why did you do that? And he says, to be buried in. So, I mean, they give warnings, even if they're subtle, to people around them, and you just, especially if the person is depressed, you've got to take these warnings seriously. Suicidal people are fully intent on dying. Well, that's not really true either. Many of them, most depressed patients have enormous pain, psychological pain. I mean, they are suffering. It's not like physical pain, but it's similar. It's brain pain. And so that seems like a reasonable way out to relieve this pain. And they actually then decide to do something, but it's a gamble. They can be interrupted. So if you talk to the few people who have survived after jumping off the Golden Gate Bridge, they will say, I got there and I started and I immediately realized that this is the end, and I did everything I could to minimize my impact when I hit the water. So they change their mind, they're ambivalent. So they're not all fully intent on dying, and any rescue is always said to, and in the end they say, I'm glad that happened. Males are more likely to be suicidal. Well, it turns out men die by suicide. They complete suicide 4 times as frequently as women. But women attempt suicide at least 4 times as frequently. In the adolescents, it's 10 times or 100 times as frequent. So depending on the age, there are more women who attempt, but more men who complete. Asking about it, this is the most important thing here, asking the depressed person about suicide will push him to think about it or to complete it. There are now very good data that show that if you ask about suicide, it does not in any way increase the risk of that person to kill themselves. So if you say, I'm worried about you, you seem depressed, and then you begin to ask about whether or not they've thought about suicide, that will not give them the idea. The idea is already there, and you're just trying to find out the extent of it. And later on I can describe those studies. And then the other important thing is that once the suicide attempt is made, the crisis is over. You know, the risk is gone. Well, that's not true. It turns out that the risk for dying by suicide is highest right after an attempt. And it's because people think because the person gets admitted to the hospital now for a short time, they're a little bit better, they have a little bit more energy, they're thinking a little bit more clearer, but they're not well. And so they're still in pain, and they really do die by suicide. The highest suicide rate is right after discharge from a psychiatric hospital. And then once a patient attempts suicide, the pain and the shame will keep him from trying it again. And this just isn't true. Depression is a recurring illness. It comes and goes. You get completely well between. Some of our authors who were so productive were manic depressives, and they had episodic illnesses. But every time a person gets depressed again, he is potentially suicidal. So that you have to be wary and worried in each episode. And then a bad event can push someone to suicide. Well, I mean, certainly events may be the final straw in many deaths by suicide, but it's usually an illness that precedes it, whether it's depression or substance abuse or PTSD or whatever. There's some final event that causes it, but it can be, it's not the cause. And that's our complaint with newspapers. They like to associate whatever's happening with the death. And they misunderstand that there were antecedents that they're not mentioning. And suicide occurs in great numbers around the holidays. And that's actually not true. Depression does go up in the fall. It is seasonal. And so, but the highest suicide rates are in April and May. And people think there's a kind of diurnal variation, and people are depressed during the winter. This was particularly true in Minnesota. And then when spring comes, they sort of begin to get out of it. Some people, that's the highest rate of going into mania if you're bipolar. And it's in that upswing that suicide rates are the highest, because people tend to have a little bit more energy and are feeling better and thinking clearer. So here are the risks. Certainly psychiatric disorders are one risk. Past suicide attempts are the second most important risk factor. So that if somebody's made a suicide attempt, that means they're more likely in the future to die by suicide than someone who has never made an attempt. Then there are symptoms, there are sociodemographic factors and environmental factors. So these are just the illnesses again. All this association of PTSD with veterans is interesting, but there's not much proof. And I'm hoping that the VA actually launches a kind of psychological autopsy study to learn more about what's going on in these veterans when they come home from Iraq and Afghanistan to see what whether it was depression or PTSD or drinking or everything together that leads them to die by suicide. And the other thing you should know is actually the leading cause of death for anorexia is suicide. So even though it's a very infrequent illness, it still is a serious illness that can lead to suicide. This is a little chart that just shows you the overlap between mood disorders on the right, I guess, and suicide attempts and then suicide. And as you can see, they're overlapping, so that there are a lot of people with mood disorders, especially women, who don't die by suicide. There are people who make suicide attempts but never end up dying. And then there are the suicides who overlap both of those. And actually, I should say, there was a recent study of a follow-up of for 20 years of people who came to an ER for a suicide attempt, which is sort of meaning a serious suicide attempt. And only 7% of them in the following 20 years killed themselves. So even though suicide attempts are associated, it's not the only thing that's going on. And then these are sort of the symptoms, and even though, again, they have to be individualized, desperation and hopelessness, so saying life's not worth living, or it's just not, future's never going to get better, things like that. And the other important symptom is kind of anxiety. I think we don't emphasize enough that anxiety is part of depression, and it's what causes the psychic pain. So anxiety, panic attacks, and psychic anxiety are all associated with suicide in a depressed person. And then aggressiveness, and some people think that's why men have higher suicide rates. They have more aggressive personalities, so being aggressive is important. And then anybody who's made a preparation, either now or in the past, is at a higher risk, so that if they've gone out and bought a gun in the past, even though they've given away the gun, they still, having made that serious a plan, they're at higher risk. And then a recent hospitalization for depression is another one. And finally, kind of psychotic symptoms. And they're subtle. I had a patient from Minnesota who I've been gone from Minnesota now almost 10 years, who I turned over to another doctor, and he has killed himself this year. And when I talked to his wife about it, he was clearly probably psychotic before he killed himself in a subtle way that nobody recognized, so that he had had prostate cancer and it was cured. I mean, it was gotten early, but he told his wife the day before he died that his body was ridden with cancer, and there was no indication. So everything was bleaker or blacker than it clearly was, and that was a distortion of reality. But it's so subtle that we sometimes miss it. These are other risk factors in the elderly: pain and other medical illnesses, and the treatment of those, because the drugs we give sometimes cause people to be depressed. A family history of trauma, childhood trauma or abuse, or being bullied are associated with suicide. Family histories of mental disorders, especially depression, and of death by suicide. So a family history of suicide puts you at greater risk, if you get depressed, to be suicidal. Drinking and drug use, and then there's this strange association between smoking. Study after study after study has shown that people who smoke have higher suicide rates than people who don't smoke. And I'm sure that's some biologic need in the brain for smoking, and the same biologic underpinnings for depression, I think. At least that's my interpretation. And then these are just other things that are true, but they don't help you, because there's so many males, and being over 65 and white, separated, living alone. All those things are interesting, but they really aren't risk factors per se. And finally, occupation. Physicians have the highest suicide rates of any occupation in the country, and that also is true, and women physicians more than men, and it's also true then of nurses and maybe social workers. The other important risk factor is easy access to lethal means. So any kind of gun control bill makes a big difference. And they actually got one enacted in New Zealand, and what they found was after it was put in place, they had to separate the ammunition from the gun and keep the gun under a locked, some kind of lock or something. The suicide rate went down. So these things that change access make a difference. In Australia and in England, they decided to package all pills individually. So you can't go to the drugstore and get a bottle of 100 Tylenol. They actually have to be individually packed, so you blister packed, so you pop them all out. And it decreased the suicide attempts from acetaminophen enormously just by causing that. So minor little things. Our change in the carbon monoxide of gas in households has changed the gassing deaths. So those kinds of things are important. And finally, there are clusters. There is a contagion to suicide. This is particularly true of adolescents, in that there are many reports of suicide. There's one in Wales now where there, I think, are 21 suicides in the community over a year and a half. So that does occur, and that's been proven also. Okay, so the way to prevent suicide, we've got a long way to go. It's education, screening, treatment, means restriction, and media guidelines. So really, preventing suicide requires public education and professional awareness, and then educational tools. And sort of this is our primary message. Depression is treatable, so you've got to destigmatize the illness, destigmatize the treatment, and encourage help-seeking behavior. And as we were talking, there have got to be enough providers, healthcare providers, to provide that care. And we actually, this is sort of preventing suicide professionally. We try we have programs for primary care, doctors and pediatricians. We also have school counselor, we're making a school intervention program now, and we have two different college programs to help educate and prevent suicide. And these are all the things that AFSP is doing. You can ask me about them later. I don't think we have time to go through them. We are just finishing a film on depression in teenage students. It shows four different students who are, one's anxious, one's being bullied by computer, one is drinking too much, and the fourth just out of the blue gets depressed. And we're going to provide that to schools starting next year. And we did another one on physician suicide, and actually Arkansas was the star of that film. We had the chairman of the Department of Psychiatry here, Rick Smith, and a surgeon physician who was depressed and treated, and they both were featured in that film. Those are the... Now, screening, we have an interactive screening that's anonymous, so that we want to put it into colleges, so that if a student is disturbed, he can log on, and then a counselor will respond to him in order to try to get him to come in for treatment. It's engaging, trying to engage the student into seeking care. It's not care, it's just engaging. And then, of course, preventing suicide requires the treatment of depression or whatever the disorder is, and here we recommend antidepressants and psychotherapy. And actually only 29% of people who are depressed have contact with a psychiatrist or a mental health worker. So the great majority do not go to their at least a professional. They might see their primary care doctor, and they could be treated there. And only 20% of people who are actually treated are adequately treated, and that's the key. So that if somebody's on an antidepressant and you know them well and they're still not doing well, they need a second opinion. They need to, you don't, if you get cancer and your treatment doesn't seem to be doing well, you probably go and get a second opinion. Well, you need to do that with the treatment of depression also. And the reason people don't take their medications is they don't like the side effects, they're impatient and they say it doesn't work, The doctor doesn't recognize their anxiety, so isn't treating that. Some of them might be substance users, and they're not telling the doctor they're also drinking while they're taking their medication. Some people are still afraid that antidepressants are addictive, and they are not. So there's that myth or mistake. Sometimes the dose isn't high enough. Sometimes the dose is too high. I mean, there are all sorts of reasons why drugs don't work. And so if you're not satisfied with the outcome in 6 weeks, let's say, then something needs to be reconsidered. And then we still have somatic treatments that are good for really serious depression. ECT is still a wonderful treatment, and one that isn't as used as frequently as it should be. And then the psychotherapies are also very good. There was a wonderful study from Philadelphia that showed that in the ER, if you talk to suicide attempters and do this kind of cognitive behavior therapy, which is only 16 weeks, twice a week, that people make 50% less suicide attempts after that therapy in the next 18 months. And these were inner city men. 40% were men, 40% were black. So, I mean, they were really working with people who don't engage in treatment, but once they got them engaged, it made a difference. So there are psychotherapies that work. Again, the problem is we don't have enough therapists. And so another big issue is training people to do these psychotherapies. And then to get the person into treatment, you have to get the person in. And so people, when I'm on a radio program, they'll say, well, how do you get somebody into treatment? I think if it's your husband and he looks depressed or something, you just say, I'm worried about you. You know, you don't seem the same, because most people change. And maybe you're depressed. Could you be depressed? You're not sleeping well. Or try to sort of tell them what you observe, and then offer to go to help them get the appointment, because depressed people can't concentrate, don't have poor memories, are very tired and fatigued, and everything is work. So they need help in starting the therapy. So means restriction, we've already talked about that. This is one of the most important ways to change suicide rates. And I don't think that we'll ever get firearm safety in this country, but we certainly have been instrumental in getting a barrier to put on the Golden Gate Bridge. So we've worked 10 years for that, and they're going to put a net under the bridge. The Golden Gate Bridge has more suicides than any other bridge in the world per year. And they made a movie about it, and after the movie was made, the suicides increased. So we've been working to get the bridge built, and we may even start to work to try to raise money to help pay for that endeavor. So that helps. And then, of course, prescriptions, detoxification of domestic gases, anything that changes the availability. In China, women have higher suicide rates than men, and most of them die by ingesting insecticides. And of course, that's a very lethal way to die. So they die because of the lethality of what they take, and because there are no doctors. So it takes them a long time to get to a doctor. And so if we could change that, the way they store their their pesticides, we might change the suicide rates in China. We have done media guidelines. We send them out, hundreds of them every year. We read every story on suicide in the country and try to get newspapers to be more responsible in the way they report it. And these are just some things we say. We don't want them to put it on the first page. We don't want them to sensationalize it. We don't want them to show the way the person died. We really want them to not report it in a way that might cause contagion. And so we then try to change that. We also worry, we monitor TV and movies and advertisements. We actually were instrumental in getting GM to take a Super Bowl advertisement off after 2 years ago. They showed a robot who got replaced and jumped off a bridge. and we wrote to them, and they did remove that ad. So I mean, we try to work on every aspect of suicide that we can. To us, the biggest fear is the cell phone instant messaging, and nobody has a clue as to how to intervene in that. So here's sort of knowing the warning signs, intervention, and the warning signs, as we've said, this pessimism, hopelessness, desperation, anxiety. Sleep problems are the other big thing. Especially, there are people who've never been good sleepers, but especially if you've been a good sleeper and then your sleeping habits change, then you worry about depression. So these are other ways: making a plan, unexpected or unexpected anger or rage, expressing a strong wish to die, things like that also might give you a hint that the person is suicidal. So show you care, ask about suicide, get help. Be genuine. Be sure to talk in the language for the age of the person. Don't worry about saying the right thing. Just try to talk to them and say, listen carefully and reflect, and don't hesitate to ask them about whether they're suicidal. Let me talk about your pain. I care about you, about how you're holding up. I don't want you to kill yourself. Just tell them outright. Talk about suicide. Are you thinking of dying? Do you wish you were dead? Does the future look hopeless? And they'll tell you, and then you have to say, this is serious, I'm concerned, I think we need to go get help. So don't hesitate, be direct, and these are the questions you might ask. This is all on our website in a speech called kind of Suicide 101. So do you wish you were dead? What do you have thoughts or plans? What do you have available? Be sure to ask them if they have a gun in the house or if they have medications or other things when you're speaking about it. And then ask them if they have a doctor or a therapist, because many times people don't talk about it. They don't say, I'm going to see a therapist because I'm depressed. And so one of the first ways to intervene, of course, is to call that family doctor or therapist or whatever. So be sure to ask them that, if they're taking medicines, and if they're seeing him or taking their medicines. And then don't leave the person alone who's suicidal. You've got to know sort of how to get to where to refer the patient. And this is particularly important, I think, in schools, that you can't start a program in a school unless you know where you can refer the person in case you uncover someone who might be suicidal. Individually, I don't think you can know the sources except a community mental health center or a children's hospital or something like that. And then these are the people that might be resources. Never forget the family doctor or the family nurse or whoever you communicate with, because they can be of help to you. And then there is the national hotline, and it's out of New York, but it really projects to every individual community in the United States. And so when you call the national hotline, the call will be sent back to Little Rock, to somebody here, so that the person here can be knowledgeable about how to help them get help. And then and also ask them if they have somebody else that might be able to help. Now, my child psychiatrist tells me that most adolescents, despite what we think, confide most in their parents, which is nice to know. And so the most logical place to go, of course, if it's an adolescent, is to say, can I call your dad, or can I call your mom? And if they say no, then you say, well, who can I call? So you make them give you a name so that you can engage that person also in your plan. And religious leaders may be another group of people who might help in this instance. Get permission to call. It used to be that people would drive out suddenly when they were upset, You know, movies show it all the time, getting the car keys and getting in the car and speeding off. So if someone is disturbed and they're in the home and the car is there, you probably should take their car keys and credit cards so they can't check in someplace and die. And then outline a safety plan. And then once therapy you've engaged someone, then you have to continually ask them, are you still seeing your therapist? How are you doing? Be sure to follow up because people will like that. And so keep engaged. And these are sort of the people that have helped us. I wrote it, but certainly other people have helped with the suicide prevention. There was a woman in Nevada when I first came named Linda Flack, who actually helped me with the kind of intervention piece. So I thank you all, and I'm sorry if I talk too long.
We do have time for some questions. If you raise your hand, we'll get a microphone to you so everyone can hear. First questions in the back.
What is the concern you mentioned about cell phones and texting?
Well, I think my impression, having grandchildren now who are teenagers, is that they're constantly talking to each other. And so they can message. There are many instances now when you investigate a death of an adolescent by suicide that right before they've died, they've instant messaged their friend at home or something, and for saying, you know, I'm going to kill myself, or they talk about it on this. I'm really in a funk. I feel like I'm, you know, I wish I were dead, and the person doesn't take it seriously. You know, they say, oh yeah, well, you know, come out and have a drink or something. So I think it's this instant communication that isn't real. I mean, that is superficial. And I just worry that people spend too much time, and internet investigations too. I mean, there are many of the kids who die by suicide have been online with their friends, and when you go to their computers, you find in MySpace what they've talked about without knowledge that this is serious. I think they talk to each other without knowledge that it's serious. So we're trying to tell people, like when we write our manual for our high school film, we'll say, you know, take these things seriously, these kinds of communications to adolescents.
In the back.
Hi, my name's Allie Turo, and I'm a student here at the Clinton School. My question is, are there any studies that show if the method of suicide is indicative of the kind of turmoil that the person is experiencing?
Well, the turmoil that the person is experiencing. Is
right.
That what, you know, the literature that goes back and talks to the people who have killed themselves show they're all in turmoil. I mean, they're all conflicted and they're indecisive and in pain. A lot of it is from the depression itself. So it's hard to compare the outside pain from the inner pain of feeling a failure, of feeling, you know, that you're a disappointment, that you'll never live up to something else, but it's part of being depressed. It's not part of the outside environment as much. Certainly there are now in the newspaper, it seems to me every third day, there's some story about someone who is in debt or lost their home and have actually killed themselves over that. But we don't really know what preceded the actual act. So I would say they're all in turmoil.
How pleased are you with the penetration rate of the educational programs that are available, like the school counselors and health professionals and so forth?
Well, the question was how pleased are we, the foundation, with these things that are available. I think we're not pleased because the suicide rate hasn't gone down. And in fact, there was this study that showed that in adolescence, the suicide rate went up from 2003 to 2004. And one of the associations was the black box warning on antidepressants. And there's clear data that pediatricians were then using fewer antidepressants. They kind of associated. And so then the 2005 data were really important to come out, and they actually showed that they'd gone down a little bit, but it was still above the 2003 rate. I mean, clearly the suicide rate is not changing, so whatever instruments we have at this point are not making a difference. I watched what the New York State schools use in New York because the state gave us the grant, and we had this association with the head of the counseling service, and he gave us what they were giving. And it was much too long and much too graphic, and it would not be something that the foundation would recommend using. And I think that's why we continually are trying to make new programs to improve that, and facilitator guides to go with the programs. What about you? Have you had any experience?
I just work for NAMI, and so he did some education, and it's never.
You know, it's hard. If you save one life, that's important. So I think it's person by person.
In a school setting where suicide has occurred, can you describe more thoroughly your recommendations of how to prevent the contagious effect?
That's a very good question. We actually are at this point involved in a collaboration with several other associations in writing a booklet called Postvention in the schools, just because that's one of our most frequently asked questions. And I'm not the expert on that, but you try to discourage the school from glorifying the death. So if it's a football player who was good at everything and then went and killed himself, you don't want to construct a memorial for that person. And we usually try to even discourage having assemblies around after the death, and sort of also making counselors available. That is not necessarily the best thing to do. I think what you really want to do is educate the kids about depression and drugs, and then ask them to talk to their parents if they think that they're having any of these problems. But it's a very complicated issue, and everyone sort of goes at it a different way. So just like the media guidelines, we are in the process of developing guidelines for postvention in the high schools or in the grade schools.
What comments can you make about suicide being a possible side effect of medications these days?
Yeah, the question is about suicide being a side effect of medication. Well, clearly, in some people, certainly in adolescents, in people up to 24, when someone starts on an antidepressant, they are at risk for kind of increased, a certain small percentage, increased agitation, and they just feel uncomfortable, and they then make suicide attempts. There's no association between medications, antidepressants, and suicide in adolescents. It's all between antidepressants and making attempts. Now, there are other drugs, like the acne drug, and there are other drugs that are now have been shown, anti-epileptics, to have some association with suicide. So I think that clearly in an individual person that's a possible outcome, but it's more likely in young people to be an attempt, not necessarily a suicide.
Paula?
My name is Faisal, student from Clayton School. My question is there any, has there been any research showing the relation between religion and the suicide rate? You know, if the communities they are religious, whether the suicide rate is lower or higher?
The question is an association between religion and suicide. And actually, there are studies that have looked at that. and there doesn't seem to be. So there's no one religion that protects you from suicide, Protestants versus Catholics versus Jews, when you look at that. And I think the Bible also shows clearly some very depressed people in the Bible. So depression you're not protected from getting depressed by religion. And when you're depressed, your thinking gets very confused. So whatever is important to you is not as important as the pain you're going through. However, there are hints, but they don't keep good records, that maybe the Muslim religion has lower suicides. We had an adolescent conference, worldwide conference in Dublin about 18 months ago, and the data from the Muslim countries maybe hinted that they had lower suicide rates. But I don't know, and in fact we just did our grant review last Friday, and we had 76 grants to review, and we funded 11, and one of them was from provinces in China with different religions, and one of them was a Muslim province, and another was a Hindu province, and so I don't think it quite reached funding levels, but I thought it was interesting because it would have helped us answer the question you're asking.
We have time for one more, right over there. Either one of you.
On one of your slides, you mentioned as far as improving or helping the prevention efforts for suicide was improving end-of-life care. Would you elaborate some on that?
Was what?
Improving end-of-life care was on the slide. Would you elaborate on that point?
Yes. Well, before I came, the medical director went to Norway and studied, because they had assisted suicide or assisted death, and studied it and came back, and the foundation took a position that they were opposed to that, and that the opposite should be true, that end-of-life care is what we should be promoting, so that people have the right pain medications and all these other things, so they don't suffer, to improve the way you feel about yourself and to reduce pain and suffering. So that was our position. It turns out more recently I was asked by Oregon to give a speech on the elderly and suicide. And so when I delved into the Oregon politics, it turns out that they have an assisted death or assisted suicide. And to my amazement, it was one of the 4 states with the highest suicide rate. So clearly their assisted deaths, which are end-of-life care in a different way, I guess, are not preventing suicide. So I'm not sure at this point that end-of-life care will prevent suicides. But it might, because the elderly have such high suicide rates, the elderly men. I mean, I think just removing guns from homes where elderly men are would be a big boost. I can't imagine if you're 85 that you couldn't get your father or grandfather to give up his gun, because most elderly people kill themselves by shooting. So. But I don't know that end-of-life care will change suicide rates, is the answer to the question.
Let's thank Dr. Paula Clayton for that presentation.